It's a huge pleasure to be back here. Thanks for the invite. Please feel free to, if we're small enough group, please feel free to interrupt me as I go along. So today I'm going to be focusing on my hypertension-related work, and the title, hopefully appealing to this group, is Increasing the Precision of Hypertension Management, and there will be no SNPs in this talk.
You don't even know what SNPs are.
Exactly. That's just my acknowledging my funders and to mention no commercial conflicts of interest. Okay, so just to get us started, I think as an intern, we deal with hypertension every day. It's easy to lose track of like the thread of the story and how this is really one of our major public health success stories. If you go back in time to FDR when he died, actually only learned this a few years ago, sort of his death was described sort of coming clear out of the blue, like, oh, how this happened. But then they actually have his medical records, and someone plotted out his blood pressure, and in the months before he died, his blood pressure was up into like the mid 200s, and I think they recorded a blood pressure of 300, if that's possible, like around the day that he died. This was all sort of towards the end of the Second World War, or just after the Second World War. So back then, we didn't even think blood pressure was something to treat. It was sort of thought of as sort of a healthy physiologic adaptation, and we didn't have any treatments for hypertension. Of course, since the 40s, starting with the 50s up until the current era, there's been dozens of hypertension medications that have been discovered, targeting all sorts of different mechanisms. And like I mentioned, this is a major success story. It's not only because of treating hypertension, but one of the big drivers of reductions in mortality from cardiovascular disease is due to how we better treat hypertension. And you can see, starting from the 50s, going up to today, the rates of CVD mortality are continuing to decline, to the point that it's making research difficult. There's just not enough events anymore. But there still is a lot of work to do with hypertension. It's sort of one of the most common chronic conditions. 1 in 3 adults are hypertensive. If you go based on the old guidelines, if you believe the new guidelines, and that's a whole other story, it goes up to almost 50% of adults have hypertension, stage 1 or higher hypertension. Hypertension remains the leading modifiable risk factor for disease globally. It's the most common reason people get started on chronic disease medications, and there's also persistent disparities in the US and other countries in who gets their blood pressure under control. And again, this is sort of the mixed story. On the one hand, if you look at sort of the rates of awareness, treatment, and control of hypertension since sort of the era of blood pressure guidelines, you can see it's sort of been a steady improvement across time. But still, if you look at sort of rates of blood pressure control, it was still when we got it up to 50%. And then if you look at the trends, more recent years, it looks like we're kind of plateauing in terms of how well we're doing in terms of getting people to goal. So with that background in mind, I thought I'd just sort of sprinkle in some cases to think about as you hear the rest of the talk. Just want to get you guys thinking about how do we currently manage hypertension in our patients. And so there's 3 very simple vignettes that any of you could relate to in your practice. The first is a 74-year-old Chinese American woman with prediabetes and an elevated office blood pressure, 150/90. The second patient is a 52-year-old African American woman who possibly had a TIA 10 years ago and has a similar office blood pressure. And then the third patient is a 50-year-old healthy woman, a Caucasian woman who also has the same office blood pressure. So again, just think through how we treat those patients. Think about which medication you choose for each of those patients, and I have one from sort of each of the first-line blood pressure medication classes listed. So I'm going to switch to how I think most clinicians think about managing hypertension. We usually start off with patients coming in with a newly elevated office blood pressure, and then a lot of us will jump to sort of diagnosing the patient with hypertension, and then we start them on sort of one of those medications. Maybe we discuss lifestyle factors and do some education as well if we're doing our job properly. And then some patients get to goal and some don't, and then it goes on as we sort of titrate up medications to get them there. What I want to talk about some of my work is trying to think about how we can become more precise in terms of how we treat hypertension, and that's what I'm going to walk you through some of the research that I'm doing that touches on that area. So one of the definitions of precision medicine, and there are other ones, but one of the common ones is the idea that it's customizing medical assessments and treatments according to the unique properties of the individual and based on their predictive that in mind, the schematic that I'll follow through for the rest of the talk is the idea that first we can be more precise in terms of how we diagnose hypertension using out-of-office blood pressure testing. Usually ambulatory might be preferred, but home blood pressure monitoring, as I'll explain, is an alternative. And by that way, we can be more precise about identifying who are the patients that are really going to benefit from hypertension therapy. And then the second part of the talk, I'll describe how once you've formed better diagnosed a patient with hypertension, you can use N-of-1 trials, and we'll sort of talk about what those are, to be more precise about selecting the treatments that are going to help that patient. And then finally, I'll talk about research that I started off in in IMA, getting mixed up between my primary care practices, where we did a project of adherence monitoring to better help doctors know who's going to benefit from medications versus adherence counseling. Okay, so first, sort of diagnosis. So I got interested in hypertension diagnosis partly because of the research group that I'm in. Our group was started by Tom Pickering, who at one point was also at Mount Sinai, and is really thought to be one of the leaders in the field who really brought to the attention of both researchers and clinicians the idea that the blood pressures we're getting in the office setting are sort of inherently limited. And some of the limitations that have been pointed out over time in literature have to do with the way we take the blood pressure, sort of the methods that we're using. And maybe we have some little room to improve on those things, but there's sort of challenges in implementing good blood pressure measurement. And those are issues like not waiting 5 minutes till the patient's really sort of at rest, not having the patient in the right positioning with their feet on the ground, or on their back against like a chair, their arm at the right level. If you're doing a manual blood pressure, letting the air out of the cuff too quickly and not really getting the proper product off sounds, and sort of having these expectation biases and rounding to the nearest 5 or the 10 units. But other limitations of office blood pressure readings are not really easily correctable. So one is that we usually only get one, maybe we get 2 blood pressure readings at a time, but we know blood pressure is inherently very variable, and so with those like 1 or 2 blood pressure readings, even if you get a few over across a few visits, it's still hard to really get a sense of where is really the sort of the mean blood pressure that the patient's living at. And then the final limitation of the office blood pressure measurement is just the setting. And I think the thing we think most is the idea that some patients do have a white coat effect in which their blood pressure is higher in the office than out of the office. And I'd heard about the white coat effect, and I seemed to see it in some of my patients, although I wasn't really doing a lot of out-of-office blood pressure testing. And this, there's been a bunch of studies trying to figure out, what is the, how significant is the white coat effect. And this is a study that really kind of sealed the deal on it, where they actually put in A lines in patients, and they had someone walk in. This is in the 80s still, probably was done in the late 70s or late 80s, and they had someone in a white coat come into the room while the patient was getting their the A line in them, and they would see sort of big spikes in blood pressure. In some patients, the blood pressure only went up a few millimeters of mercury, but there was other patients who went up to like 60, 70. If you trace the black lines on sort of the top row, you see sort of big jump in the blood pressure up to like 75 millimeters of mercury. And then if you follow, I don't have this up, but if you follow to the other arrow when the doctor leaves the room, the blood pressure starts coming down again. So this is like a very proven physiologic effect. Patients don't always say they feel anxious at the time. So you can't use that as a reliable indicator as to whether someone's likely to have a big white coat effect. And so because of that difference between the office setting and sort of the setting in which patients live the rest of their lives, it's hard to get a good blood pressure alone in the office setting. The white coat effect, and so intuitively it would make sense that the office blood pressure isn't really going to be the good marker of cardiovascular disease events if it's sort of just this sort of temporary elevation when the doctor walks in the room. And that's sort of borne out in the majority of epidemiologic studies. This is one such study, which they had a huge cohort across multiple countries where they had in-office and out-of-office blood pressure measurement. And they showed that the sort of the bottom 2 lines were patients who had normal tension, so blood pressure not elevated either in the office or out of the office, and then white coat hypertension, those who were elevated in the office but normal when they're measured out of the office. And in terms of the cardiovascular disease event rate, it was very similar in both groups. And that's been the majority of the epidemiology. There are some examples. There was a recent New England Journal paper, which would be a longer discussion to say why that data may be flawed, which was suggesting that white coat may actually confer some risk. for the most part, I think most hypertension experts think that it's a benign phenotype. Maybe we wouldn't care that much about white coat hypertension if it was sort of a rare, uncommon finding that, but in reality is thought to be quite common. There's actually currently not any great U.S. national estimates, although the CDC is sort of thinking about adding it to the NHANES study. But for right now, it's just sort of a bunch of studies in all different settings, and the rates range from 5 or 10% up to 60% of patients having white coat hypertension. And again, overall, people think it's about 1 in 5 patients who have a newly elevated office blood pressure, but the exact rate isn't clear. So because of both the fact that white coat is pretty common and doesn't seem to confer increased risk, in 2015, the USPSTF updated their hypertension screening recommendations to say that we should get out-of-office blood pressure measurements before newly diagnosing someone with hypertension. And this was sort of still an A-level recommendation. And because of that, ambulatory monitoring, which previously was only covered by Medicare, is now also reimbursed in Medicaid. There are some caveats, like if someone clearly already has cardiovascular disease or has severely elevated office blood pressure, then they say you can probably move straight to say that they're diagnosed. But for the remainder of patients, they do recommend out-of-office blood pressure screening. And this recommendation really follows on the heels of most other recommendations in developed countries, and these sort of hypertension and cardiology societies have sort of already recommended this. So there's a lot of support. So we started thinking about how often are these tests being used. I mean, I had never done ambulatory monitoring testing when I was working at IMA, and similarly at Columbia, there wasn't anyone that I knew was getting it other than maybe the nephrologist. So we sort of looked to see what data there was, and we actually looked at data within our own primary care network, and we found, in 2014, across 524 visits in primary care setting where patients had what looked like a newly elevated office blood pressure and were already on hypertension treatment, home monitoring was only recommended in 1% of patients, and ambulatory was never done, primarily because other people weren't aware that this was an important guideline, and at that point it wasn't part of the formal guidelines, but also there wasn't anywhere obvious to get the test done. And then one of my colleagues looked at the rate of ambulatory ordering within Medicare, and basically it's a very infrequently ordered test, and the majority of times it was ordered, it looked like it was more for patients with uncontrolled hypertension on lots of drugs, trying to figure out is it because they have a white coat effect, but not as part of hypertension diagnosis. And so that led to a grant that I'm working on, in which we have funding from HRQ to develop and test a implementation strategy to sort of try to implement these new USPSTF guidelines. Sometimes, I don't know if it's a critique, but people sort of notice that the USPSTF comes up with these guidelines sometimes, it's not really clear that they back it up by strategies to help people implement them, and we don't always have an uptake of the guidelines. And so part of this was also geared around the more general idea is how can we get patients to update and implement recommended guidelines. So as part of the study, we first did some focus group and interviewing with both patients, providers, and stakeholders in our primary care clinic network to find out what the barriers were to out-of-office blood pressure testing, and some of the providers at Mount Sinai also helped be in one of the focus groups. And so the main things that came up, some of them not really surprising. One of the main barriers for ambulatory monitoring was that it just wasn't something that they knew how to access. But the other barriers had to do with lacking knowledge in how to conduct ambulatory blood pressure monitoring, a lack of confidence in the benefits of the testing, and in terms of home monitoring, those people who are familiar, I can order a home blood pressure device, but the idea of sort of teaching patients how to do it properly, and sort of being concerned that the patients are going to over-monitor and sort of going to drive health anxiety, sort of other barriers to the home blood pressure monitoring. So based on those barriers, we used an approach to intervention development called the behavior change wheel, which some of you folks who are getting involved in implementation science might be familiar with, in which uses sort of very structured approach to link interventions and behavior change techniques to specific barriers. And out of that, we created our implementation strategy. And so we did things like we actually created an ambulatory blood pressure monitoring service and made it easily accessible to our providers. create a series of trainings and resources to make it easy to order out-of-office blood pressure testing. We're giving providers feedback on sort of the rate of ordering and the rate of white coat hypertension diagnosis. And we also were sort of empowering the nurses to help out with the teaching on home blood pressure monitoring. And basically, we have a network of about 8 primary care clinics, which we've randomized, and sort of ongoing, we sort of have implemented our strategy, and now we're sort of tracking to find out what the outcome is going to be. So that's a little bit about being more precise about hypertension diagnosis. Now, I next want to switch to talking about how we're using N1 trials to help become better at selecting blood pressure treatments. So thinking about back with sort of initial cases, how do we initially think about selecting blood pressure medications? The guidelines say you can pick from one of any 4 blood pressure medication treatments as sort of our first line medications. And I think we often do that. I'm not sure what do we think about when we pick one versus the other drug. Is it just we have one in our left pocket? Do we pick thiazides all the time because of some JNC7 findings? Or is it sort of a haphazard thing? But I think we rarely sort of ask patients which blood pressure medication do you want to be on. And then, we follow patients up usually as sort of sporadic clinic visits and, until patients get to goal, and we sort of keep on adding medications. And on average, about 70% of patients require multiple medications to get to goal. And, if you are going to follow sort of the more intensive blood pressure guidelines, that's sort of pushing people up to almost sort of needing 3 blood pressure medications. And, a lot of my work's been around medication adherence, so I know very well that the rates of adherence are very depressing at times to think about. So in terms of just what they call primary non-adherence, the amount of patients who, you give them a script and they don't even fill it at the pharmacy, is thought to be up to 1 in 5 patients do that, and that's true for cardiovascular medications as well as other classes. And then amongst those who we sort of engage in their regimen at all, about 40%, even up to 50%, discontinue the regimen within the first year. And so now I'm going to shift to sort of the rationale for why N1 trials might be possible solutions to, maybe not overcoming this entire problem, but maybe moving the needle a little bit. And that's the idea of heterogeneity of treatment effects. So I think when we think of a randomized controlled trial, we often, that shows a positive finding, that shows a treatment benefit. We often think, oh, well, now that's a good treatment, I can use that treatment on my patients. I think what gets lost in the interpretation is sometimes the idea that that's what's true for the average patient in that particular trial. And within that trial, there's actually a distribution of the benefits and the harms of the treatment shown in sort of the figure on the slide. And so if it's a positive randomized trial, then maybe overall the majority of patients are in that green area where they had a net benefit. But for a lot of our treatments, there's actually a lot of patients who have sort of no net benefit compared to the harms, and there's even some patients who actually have harms. So I think, I think we're always aware of the idea of harms and side effects and complications of therapies, but I think we don't always know how to sort of fully integrate that into the way that we prescribe medications. And so in terms of blood pressure medications, how does that apply? There's actually a bunch of literature going back to the 80s and early 90s where they first tried patient randomly on 1 of 4 blood pressure medications from different classes, and they found that less than 1 in 3 could achieve blood pressure control on a single drug. But then they did a thing where they sort of did a trial patients on each of the 4 classes of blood pressure medications, and then picked the one that the patient had the best response to. And they showed that by doing it that way, you can get 3/4 of the patients under control with a single drug. So that there does seem to be a heterogeneity, not just in the side effects that patients experience from blood pressure medications, but also sort of the amount of blood pressure lowering effects that the drugs have. And so this really fits with the idea of sort of precision medicine, the idea that there are different benefits that people get from drugs. For blood pressure medications, there's lots of different physiology for what underlies why some people have hypertension and other people don't. And so it makes sense that maybe you need to find out what's the right pathway for that patient, and then you pick the right drug that addresses that pathway. So I think that's the idea that underlies pharmacogenomic approaches. I mentioned no SNPs, I kind of lied a little bit. There have been a lot of people trying to understand the pharmacogenomics of hypertension drugs. And without going through the studies in any detail, despite a lot of effort going into that area, so far no one's really figured out, if you have this SNP or this genetic or genetic product difference, that I could tell you which pathway you're on and which drug you're most likely to benefit from. So people have been looking, but so far there hasn't been a lot of success in that area. There was a time where people sort of used hormone levels, like aldorenin levels, to try to figure out which pathway. And I think some doctors still sort of follow that a little bit, but as far as I understand, that hasn't really been validated as a useful approach to, unless people really have like hyperaldosteronemia or something like that, to deciding which class of medications people should be on. And so thus far, we still don't have actionable biomarkers to guide treatment selection. And so what else can we do? And that's the idea of N-of-1 trials. So I've been using the word N-of-1 trials throughout the talk. I'm just curious how many people are already pretty familiar with that sort of study design. So maybe about half the people. So I'll just briefly go over what it is. It's pretty simple. The main difference about an N-of-1 trial, just like in the title suggests, is an experiment you do within a single participant, and the patient trials 2 or more treatments within themselves using a multiple crossover design, and sort of over time systematically collects data on the effects of treatment, and then use some of the tools that we think about as sort of conventional randomized controlled trials to get better rigor in terms of understanding whether there are true differences between our treatments. So you can do things like randomizing the sequence of the treatments. You can use blinding or placebos to compare, a new treatment to a sham treatment. And then there's rigorous statistical techniques you can use that account for time series effects, or sort of autocorrelations and measures across time, to get more robust understanding of whether the differences are truly statistically significant. And then we're sort of coining this word personalized trials as a subtype of N-of-1 trial that's really patient-facing, where the goal is really to bring data to the patient-doctor setting. And so the idea is sort of not only obtaining the data, but also presenting the data in a manner that doctors and clinicians can easily understand, so that they can then participate in decision-making over, if they track some of the harms and some of the benefits, they can sort of put that together in a way that makes sense for them. So it's really a way of sort of enhancing shared decision-making around selecting treatments. And so we've sort of been thinking about, is it possible to apply this design to how we initially select first-line blood pressure medications for patients. And so we have a sort of a pilot study underway, and I'll present you some of the data, in which the goal is to get a sense of the feasibility approach. If we find patients willing to do this, and it's something that patients find satisfying to do, and then also secondarily, are we finding that patients are more likely to sort of pick one class of medication over another when we do the trial and sort of experiment this way. So this is the example of the protocol that we're doing. So you see there's sort of a sequence of 3 classes of blood pressure medications. We picked amlodipine, losartan, and hydrochlorothiazide. And patients sort of take each of those medications for 2 weeks at a time, and they're asked to do home blood pressure monitoring in the 2nd week. So they kind of have 1 week to get the drug into their system, and then sort of 1 week where they're not tracking, where it can sort of titrate out and get the next drug into their system. And they track their blood pressure using home blood pressure monitors, and they also get like a daily reminder to complete a side effect question. And how does this differ from sort of our usual trial therapy approach? Is we're getting not just a one-time blood pressure in clinic like 3 months later, with them recalling if they did or didn't have side effects. So you get sort of much more real-time ecological data that's thought to be more rigorous, and you're getting a lot more measurements in which to decide how the treatment's working or not. And then we it sort of goes A, B, C, and then CBA. So the patients are doing the comparison twice. And so the more repetitions you do, the more robust or rigorous you can sort of have data to really say that the differences are not due to the random effects of time, but due to true differences in the physiology, the effects of the treatments. Yeah, please.
So in this trial, it's critical that you really go beyond the washout period, and it seems that both for effectiveness and side effects when you have the drug, seems this is really short. Like 2 weeks, like a week, like a few days out of losartan, you probably still have like some effect in your system.
So we purposely avoided like chlorothalidone, which has like a very long half-life of like 20, 30 hours or something. So, but the other drugs, the half-lives are like less than 12 hours, when some of them are like more like 6 or 8 hours. And so it's thought that they would at least have had multiple half-lives for the drug to titrate out of the system. But I still do have that concern that there may be other downstream effects
physiological
that
changes
physiological
that may
changes
take that.
that could happen. Yes, that is one possible limitation. People have looked at this a little bit with some of the medications in the past, not thinking about it as an N-of-1 trial, but sort of understanding the physiology of medications. It seemed like it would be enough time. In theory, especially if we have enough data to sort of start pooling together in sort of a Bayesian way, you can start trying to model whether the medication, the blood pressure seemed to be still sort of coming down, like whether there was a trend in what was going on with the blood pressure across the different periods and as a sort of between the washout period and the onset period. So we're hoping with our statistician that we can sort of bring more, like overcome some of those concerns. But yeah, that is one limitation. N-of-1 trials work the best when you have very short acting medications and you can do lots of repetitions. And so one of the use cases that they've been done the most for is for like amphetamines for ADHD, where the drugs are thought to have a very quick effect and to wash out very quickly, and you can do several repetitions. Because one of the things we run up against is, yeah, it would be great to like have a 1 month period of each medication and a true washout period. But then you start stretching out the duration to across multiple months, and then sort of the willingness of a patient and the clinician to sort of do that experiment, becomes less. So that is one of the things we sort of want to test using statistical techniques, whether the 2 week period with only allowing 1 week for washout is really enough of a chance. So any other questions about the N1 design? Okay. So now I sort of want to show you some of the results. So sort of thinking back to those first vignettes that I talked before, I'll just think about, which medication would you pick for each patient? Just sort of pick the same one for all of them, or, trace this, you sort of would get different answers with the N-of-1 trial. So the first patient was the 74-year-old with pre-diabetes. These were her results. She had a pretty clear separation between hydrochlorothiazide and losartan and amlodipine. You could say all medications also did get her goal, but most people would want to be on the most potent medication. And then I didn't show her side effect data because she didn't really report side effects to any of the medications. And when she was sort of showing all her data, she chose hydrochlorothiazide for sort of chronic therapy.
Yeah. Sorry, just a question. So in that personalized case, was she explained that there may be some benefit of losartan related to her pre-diabetic state? I mean, just, not that it's definitive, but was that part of the discussion after she said, "No, I'm going with that"?
So we didn't. I mean, so the literature, the guidelines say that ACE or ARB is recommended if you have proteinuria and diabetes, but diabetes alone is an indication, and pre-diabetes isn't also. Though again, I know like a lot of doctors say, oh, pre-diabetes might turn into diabetes, and I might as well just pick the one that'll be on board for the long term. So that could be a very reasonable decision you would make just to pick losartan or as the drug for that medication. We didn't go into that level of discussion with the patient, saying you might have to switch later on. But that's something I did think about with this case. Yeah, please go ahead.
How are you measuring adherence for medications? Like, were patients reporting it, or were you checking blood work?
Great question. So ideally, we're hoping to sort of bring, the goal is to make the trials as easy for patients to do as possible. They were asked to sort of report each day on to take their home blood pressure readings and sort of complete the side effect questionnaire. So we did have a sense they were very engaged in both of those activities, and all the patients did those things on at least 80% of the days that they were asked to. But we were planning to, in a future iteration, now that we have more funding for this scope of work, to actually bring in like electronic pill bottles that can wirelessly transmit data. We're also hoping to use wireless blood pressure devices so that patients, in this case, we didn't have the wireless devices, except if patient had their own, one patient had their own wireless device. But then that way the data can like come to us without having to sort of email us or write down by hand what their blood pressure readings were. So in the future, we're hoping to sort of bring in the adherence data as well. This was the second patient. This was a 52-year-old African-American woman with similar blood pressure. And some people might have thought, African-Americans in the guidelines, there is some precision in the idea that calcium channel blockers or diuretics are thought to be first line in African-Americans, so I could see where your head might have gone in that direction. But we still tested all 3 of this patient, and she did the best on the losartan and the amlodipine. or the other, but then we also had the side effect data. And for her, she actually didn't have any side effects to the losartan, but with the amlodipine, she actually had been on amlodipine in the past and hadn't really recognized it, but during the trial it became more clear to her that she did have increased swelling with the amlodipine, which is a common side effect. And because of that, she ultimately chose losartan as her preferred long-term hypertension medication. And then the final case was a 50-year-old woman, the same office blood pressure. And here we actually, I don't have any data from an everyone trial because we actually offer patients the option to do out-of-office blood pressure testing prior to doing the trial of medications. And so she did ambulatory blood pressure monitoring and found out that she had quite good hypertension. So she didn't have to do the trial of blood pressure medications. And then, so far, again, we've had a small number of participants go through the trial. We've just had 7 patients so far. And these were, pretty engaged patients who really wanted to understand the effects of blood pressure medications on them. And so I clearly understand that this is not the problem for addressing our patients who are on medications and, are not adherent for many different reasons to taking their blood pressure medications. This is sort of geared at people who are more sort of newly started and have a curiosity in how blood pressure medications affect them. And so within this group, there's a high rate of compliance to the study protocol. All the patients said they'd recommend such an experiment to other people. Some people, and in terms of the preferred blood pressure medications, 4 preferred the thiazides, 2 was either an ACE or an ARB, and 1 there was no clear preference, where they had a similar lowering on multiple classes. Even that patient though still sort of enjoyed the experience of the trial. I think patients, at least this group of patients, they get a lot of benefit from just self-monitoring and learning, maybe how they just did a lot of home blood pressure monitoring without the experiment of taking different medications. They would have had a similar benefit, but I think, at least for this group, they really enjoyed, one of them was actually a physician herself who did the study, and she raved about doing the experiment and thought everybody should do it. She was like, I think a psychiatrist, but still. I think, some people get a lot of self-knowledge and sort of confidence about understanding. It's the idea of the variability in blood pressure, from day to day, sort of conveyed an understanding that's all about the averages, I think. And so the idea of participating in their treatment had a lot of these sort of collateral benefits that were not only about, getting exactly the right medication. So I think there's a lot of other reasons why this approach may be useful for practice. Yeah.
How did you select as you recruited patients? Patient or selected people who would be responsive to this?
This started out as a unfunded and then small funded project. So the initial recruitment was a lot of it was through word of mouth, sort of letting people know in our research center that if they had, family members or friends who patients were eligible if they were on no drugs and sort of newly heard that they might have hypertension, or if they're just on one drug and we're willing to do a trial of 2 or 3 drugs to find out which one was best. So a lot was word of mouth. One of them was my own patient that I sort of identified in my own practice. So it was it wasn't like a public health approach to dealing with millions of people with hypertension. I think our idea of it, this was one experiment around hypertension. We're developing a platform to do N-of-1 trials across other use cases. And I think we think of it as maybe you start with the early adopters, with the more tech-savvy, self-monitoring types of people, of which there's a growing number of patients who are sort of taking health into their own hands and are sort of doing their own, uncontrolled experiments with a lot of therapies. But the idea is that maybe if we get the nuts and bolts of sort of doing these as an unobtrusive way as possible, that maybe in the future could be useful for a greater slice of the population. Yes, it is signed for consent. And we asked for permission from the provider that would be okay for them to start a trial of different medications. If they already have established cardiovascular disease, then we would say they're ineligible, at least for this iteration of it. Yeah.
I see that 6 out of 7 chose medications that would require some periodic blood test monitoring.
Yeah.
I'm curious, was that part of the discussion when you were sort of offering them their choices, that they were sort of made aware of that? Because I know sometimes that's an issue when you're talking to patients who just don't want blood drawn.
Yeah, great question. So when I've talked to sort of primary care providers about how they choose the first-line medications, what comes up, if a patient they're concerned is not going to maybe is an escape threat is not going to come back to practice, then they sometimes pick calcium channel blockers first line because they're not worried about the electrolyte abnormalities. The guidelines are not super strict about how frequently you have to check electrolytes, so we made sure that patients had a pre-blood test in terms of their electrolytes and that they didn't already have any abnormalities prior to the trial. We didn't test the post-electrolytes, sort of let them do the trial without checking, and then if they're going to end up on the diuretic or the ACR, we would let the primary care provider know what the results were, and sort of up to them to sort of follow up at the end in terms of electrolyte abnormalities. That is another concern that we had, that is that safe? Our providers are not concerned about that because it's sort of a short-term use case, and we often don't check electrolytes until people are on drugs for 1 month or longer, and so this was still within that window.
So were they coming back every 2 weeks or just at the end of the?
They just came back at the end, and actually for a lot of patients, it was all just done over the telephone. Like they came in for the initial visit, we did the informed consent, but all the rest was done just through email or telephone or text message in terms of them self-reporting their data. But then reviewing the results, we sort of sent them a PDF through email where they'd have the slides in front of them. What we're developing now is we're actually creating, and we have it for one project, we're actually creating an app so everything can be done on your smartphone. Yes, the goal is to make it as easy to do as possible, and not make people come back from multiple visits along the way.
Provided BP cups for them, or?
If they didn't have one already, yeah, we give them a blood pressure monitor that was validated. They had to have a validated device. Yeah.
The other group that's challenging are the people that have had a side effect to every drug I've ever had.
Yeah.
So that might be another group that would be helpful to actually really do it.
Yeah, that was actually a little bit what inspired the research. Is when I first went to Columbia, the hypertension program had closed down a couple years earlier, and those people still call our office sometimes asking for advice. And so there was a patient who had side effects to every medication, and Kronish Davidson, who's sort of the director and one of my mentors, had recalled this sort of methodology when she was a psychologist and treating patients with ADHD back in when she was doing her training. And she was like, oh, why don't you do a random one trial with this patient and have them test out and really learn if she's truly having side effects to the drugs. That patient was not interested in that approach. There's just other concerns that, but that was one of the inspirations for this whole study in the first place. And when we've talked to providers, that's a use case that they find really helpful. And there was an N-of-1 trial published in Annals of Internal Medicine a few years ago that had just 8 patients in the whole study, in which they did an N-of-1 trial for statins, and those were patients who had discontinued because they thought they had myalgias from the statins, and they did an N-of-1 trial of sort of statin versus a placebo, and they found out that none of the myalgias, at least in those 8 patients, were truly attributable to the statin, and they convinced 5 out of the 8 of them to sort of start a statin after the experiment. So you can see you can get a study published with just 8 patients. So one of the other exciting areas, I think one of the potentials of this approach of N-of-1 trials is that, while the personalized trial is all about informing that individual patient doctor treatment selection experience and hopefully, getting bigger buy-in for your patients and hopefully longer-term adherence to the treatments. But you can also use this to sort of broadening out in terms of thinking about more public health implications. So if you get multiple people doing N-of-1 trials, then you can start pooling results across individual patients, and it's sort of like doing an individual level analysis where you can sort of pool results and then start getting study population level understanding of benefits. And statistically, if you get that methodology, it's thought to be more efficient. You need much fewer patients to get an understanding of differences across a population. So let's say there's a new blood pressure medication, or makes more sense, sort of new migraine medication or something. You don't yet know if it works. You can, instead of doing a conventional randomized trial, you can get a lot of people doing N-of-1 trials and then pool the results that way. The other cool part about if you can build sort of a registry of N-of-1 trials is you can find out who are the people that had a clear separation, sort of what's called deeply phenotyped or sort of extreme phenotypes. So if you think about blood pressure medications, who are patients who had like a whopping drop with hydrochlorothiazide but not with the other medications? And then that's something useful to the genomic folks. Because a lot of problems with the hypertension pharmacogenomics is they didn't really have great blood pressure measurements, and the patients aren't really well set of experiments that anyone can do in the do in the community, and then patients can sort of sign a consent to sort of de-identify, but make their data publicly available in a registry, and then eventually we can this is our long-term ambition. You can sort of pool data and sort of identify extreme phenotypes. I'll probably skip over this for sake of time, or just go over very briefly, but we also had a grant from PCORI, which we internally called sort of our market research grant. We didn't say that to PCORI. But the idea was sort of find out, N-of-1 trial, a few people raised their hands that they'd heard about N-of-1 trials before, and in the literature, N-of-1 trials were sort of had a fad, perhaps you say, in sort of the mid-80s to late 80s, when Gordon Guyatt, who sort of really thought to be sort of the godfather of evidence-based medicine, sort of did the first published N-of-1 trial in the Journal of Medicine, and got people excited about this methodology, but it never really took off. And we were interested in trying to understand what is in the current environment, what are attitudes by patients and primary care providers toward the study design? Is there more fertile ground now for doing N-of-1 trials? And the things that we think are different nowadays is, more patients have taken health into their own hands. The idea of sort of tracking our health is sort of something people do much more now than in the past. And we also have mobile health tools to make it a lot more easy for patients to do these experiments. When they did them, in the 80s, it was all sort of paper and pencil, mailing things back in or coming back in person for lots of visits. And the amount of burden, both for like the clinician and the patient to the experiment, was to the point where it was just proving to be too expensive, and we weren't getting a lot of volunteers to want to do it. But we're hopeful with sort of the area of sort of put it all in an app, and so that the doctor doesn't have to redesign it and get approval and figure out the statistics and all that. If we can make that as easy for people as possible and make it easy for patients to do all the self-tracking, that maybe nowadays there's going to be more interest in buy-in. So we did a bunch of focus groups, and we did some national polling around the idea of N-of-1 trials, and this is just a little bit of the data where we asked patients which chronic conditions they would be interested in doing N-of-1 trials for, and hypertension came back at the second most popular one, probably because that's the second, probably one of the most common conditions. But the other common use cases were for chronic pain, insomnia, depression were all up there. And those are some of the use cases that we've been sort of designing N-of-1 trials around. We had one experiment recently where we did a trial of bright light therapy for depressive symptoms. And we're working on an N-of-1 trial where people can compare melatonin at different doses to a placebo for chronic insomnia. And we're also thinking about experimenting for chronic pain using sort of complementary medicine approaches that at least have fast enough onset and withdrawal to sort of fit the design. Even have websites if you want to learn more about it. We put a lot of information there that would be useful to clinicians to understand the study design. Okay, so I'm going to end just with the study that started off at IMA around the time that I went up to Columbia, and that went the idea of how could we be more precise in our patients who have uncontrolled hypertension. And sort of the underlying rationale for that was, amongst patients who are uncontrolled, we're not really good at knowing which patients are uncontrolled because they need more medication, or which are the patients who are controlled because they're not taking the medications that we're already prescribing. I think we usually tend to just keep on adding medications because we don't really feel like, if we think about the adherence problem at all. And I think this contributes to sort of people being on lots of drugs, some of which they're not taking. So as part of our study, we enrolled a cohort of patients that had persistently uncontrolled hypertension at 2 or more primary care visits in a row, and we objectively measured their medication adherence using an electronic monitor, and we found that these were patients who were engaged in treatment, signed up to be in our study. We tried to downplay the idea that it was like Big Brother watching them, but they did know that we were going to monitor their medication adherence, and still over 40% took their medications less than 80% of the time. And physicians, I think primary care doctors understand that non-adherence is a major problem, but maybe it's just so hard to figure out who is and who is not taking their medications. And so we bring biases to that, so who we think is non-adherent, so we can overestimate the wrong way. But I think for the most part, we often overestimate our patients as being more adherent than they truly are.
So we also really don't know what to do with them.
We don't know what to do with them. Right, and it's hard to, unless patients are going to admit it, we'd rather keep giving them more
And
medications.
even if they admit it, you're like, now what do I do?
Right.
Like, I'm not taking it, like, okay. I'm just gonna stop prescribing it.
Right. I mean, I'll bring that point in one other minute, just with another study that came out. We also looked at, so some people think like, well, if our clinical gestalts or whatever little questions we ask are not that helpful in figuring out who's non-adherent, then maybe people create a lot of tools. The whiskey is a whole long story to get into if you want to go for a beer. I'm so concerned about that, but there's a lot of self-report tools like the whiskey adherence questionnaire. The VS is sort of a single item visual analog scale where you sort of put an X on a line between 0 to 100%. Patient says how often they think they take their medications. But we looked at how well those tools did compared to the electronic sort of objective test. And while the specificity was pretty good for, patients say they're non-adherent, they usually truly are non-adherent on these instruments. But the sensitivity is still crappy, and they're still not really good at detecting who's non-adherent. So our experiment was to use objective adherence monitoring to figure out of the persistently uncontrolled patients who are non-adherent, and then to give the feedback to doctors in real clinical time. Around the time I was designing this experiment, I started getting reports in the mail. You guys probably still get them for the managed care plans that sort of tell you, oh, here's your refill data on your patients, but it kind of comes asynchronously. You don't know, who the patient is at the time that you get the report, and I think, I don't think they're used very effectively to change physician behavior. So our goal is really to get the data in the hands of the clinician at the time that they were seeing the patient and had a blood pressure, to correlate it with. And then we gave a little bit of advice as to what to do if the patient was not adherent, but it was, it was just some bullet points of things that you could think about. It was a fairly low touch in terms of, we didn't do like lots of individual training with clinicians, and it was more just sort of on the report. These are some common things that may make sense. The control group had their adherence monitored, but it wasn't shared with the clinician. And this would be the type of report that the physician got. Some of you guys got these reports. This would have been a report for an adherent patient. You can see like everything's in the black. They took all the medications for 80% of the time. And I know, I sort of piloted my own experience with it. And, I definitely had a couple of patients who, I was sure they were going to, they seemed like they were, frustrating their medications to the visit. They had language barriers, all kinds of things. I was sure that they were going to have like really low adherence, but it came with this type of report, and that gave me more confidence to be more aggressive that they really did need the 4 medications or 5 medications to get to goal. This would have been a report for a non-adherent patient, where we'd sort of show the adherence per drug and across all the drugs. And the idea is that with this report, you might have open the door to a discussion with the patient, and maybe inspire better adherence in the future. And this was the main outcomes. We actually showed, the main goal of this was sort of a K-word study, which was, the idea was just to show whether this tool could change physician behavior with the downstream consequence for a future study to see if this could really move the needle on blood pressure control. And we showed, it's hard to change physician behavior, but we showed that, by giving the data to the doctors, they were more likely to intensify the regimen for adherent patients, and they were more likely to at least document in the chart to the best that we could that they're doing adherence counseling for the non-adherent patients. So I can say this is sort of an intermediate outcome. In the future, we sort of want to see whether this really help blood pressure control. Another question that came up in the study, though, was I think a little bit in the direction she's going is like, well, then what do you do? And there were some papers. There was a paper that came out of the HIV literature where they did a related type of experiment, and then they actually audio taped the sessions between the patient and the doctor to find out what communication was going on. And they found out that there was a lot of sort of closed-ended, directive, thought to be not patient-centered communication going on, and they were concerned that the information could actually be detrimental. Is it like doctors waving their fingers, or maybe it's actually going to lead to worse relationship and worse adherence. But we were pleasantly surprised. The clinicians came from IMA and from sort of the IMA equivalent up at Columbia, and patients actually reported higher level of patient-centered communication when the doctors got the adherence reports, and they were more likely to sort of rate the hypertension care as being very good or excellent. So I think at least we had a signal that it led to sort of productive communication between the patients and the doctors.
Sorry, who's rating this?
this was the patient. So at the end of the visit, the research coordinator met with the patients and then we filled out a little post-visit questionnaire. Just to get to Eva's point, the one other experiment that sort of touches on this area that was that caught my attention, and Ethan Holm actually was a co-investigator on the paper. They did not electronic monitoring, but they did drug level monitoring. So it was a relatively small group of patients, like it was around 50 or 80, who were actually referred to a hypertension specialist and were on multiple medications, severely uncontrolled hypertension. These were patients who were showing up at the hypertension doctor's office, and then they drew drug levels. It's actually cheaper and easier to get drug levels either from a urine test or even from a blood spot. You can now get a drug level rating. And they found out that I think 40 or 50% of the patients had like 0% of the drug, at least the detectable level, at least for one of their medications. And I think it was about 20% were not taking any of their medications. And again, these were people who were like engaged enough to like show up at their hypertension doctor's office. Like that's, if it was just like a random primary care visit, that wouldn't shock me. But the fact that it was that they actually were showing up at the expert's office, in theory, for help with this problem, was what kind of surprised me. And then again, this was a non-randomized study. Then they sort of tracked what happened at the subsequent visits, and the blood pressure like plummeted beyond what you would think would be sort of regression to the mean, because they had already had this persistent elevation to get to the hypertension specialist's office. And then they sort of asked the patients, I forget out how they did it, but they sort of found out what were the reasons that were disclosed after the, once it was shared between the doctor and the clinician, the report, then a lot of patients sort of disclosed like, oh, I'm really having side effects, or oh, I'm worried about affording medications. Like sort of the real underlying reasons finally came out. And it just reminded me, like patients, I've also seen in my research and interview who've sort of done, questionnaires with patients. The answers they give doctors versus other people are very different. Even patients we have great relationships with, some of them want to impress us, or there's all different psychology as to why it's really hard for us to get the underlying reasons. And it may be that if you sort of create this open disclosure, that you can sort of get at the more honest reasons and then be able to sort of address those concerns and improve adherence. That's the theory, at least. So we're kind of out of time anyway. I'm happy to take a few more questions, but that's what I wanted to review with you today. That's sort of three different ways of thinking about trying to be more precise with hypertension management. One is through increasing the use of out-of-office blood pressure testing when we diagnose hypertension. The second is seeing if we can sort of broaden this idea of N-of-1 trials to be more precise and create better shared decision making around selecting blood pressure medications. And then the final one is if we can bring better adherence data to the doctor's office and then hopefully become better at deciding who needs more medication and who needs more of that conversation around non-adherence. So I'll stop there and happy to take any.
Quick question. Do you, for the reminders of the side effects daily, do you call them or do you text them? How do you remind?
The way it was set up in the initial sort of piloting version is they had the option of getting emails or a text message. So like it would be set up at the time that they wanted, usually of course sort of 5 or 6 p.m. They would sort of get a daily reminder. So it was sort of automated. So it wasn't the study had to call them every day. So they did have to have at least access to text message or email.
You said as your first teaching point, our takeaway is get out of office measurements. I try to give a blood pressure cuff multiple patients. I get 5% back with the measurements. Has there been any success or anything successful intervention that you found to encourage them to bring back out of office measurements?
Yeah, so great questions. We have been thinking about this because it's useful. There's a growing amount of data that home monitoring is useful for patients who already have, already on hypertension medications. Usually in conjunction with some other intervention, but home monitoring can help lower blood pressure. There's been meta-analysis on this topic, and there's a lot of enthusiasm for this in the hypertension field. So I am trying to increase the use of monitoring in my patients. So one thing is, I think there's confusion over when does insurance pay for home devices, and I have, the majority of my patients have Medicaid, and so Medicaid does cover home blood pressure devices in New York State. It's state dependent, but they only cover a couple of the inexpensive ones. And so we actually created some materials, which I'm happy to share after the talk, where we have we have 2 blood pressure devices that are commonly both validated and available at sort of area pharmacies. One of them sort of the on-run 3, for those of you who are familiar with on-run. So we actually give them it with the picture and tell them to bring this to the pharmacist and ask them if they have this one in their store. Because if they bring the wrong one to the front, then it'll show that it's not covered, and I don't know if the patients don't understand why. So that's one thing, is sort of try to get them, the people who affordability is an issue, try to make sure they can get the good device. The second is, like I said, we did do some training with the nurses. A lot of them were pretty familiar with home monitoring. We sort of explained what the protocol would look like. And I think sometimes we don't do enough training of patients of how to do it, and that might drive the sort of patients getting the sporadic measurements when they're the most anxious and when they have a headache, as opposed to the rest measurements that it's supposed to be. Yeah, and then how to get patients to actually bring the devices back in, because people do forget them. Haven't proven that it's helpful, but I think making it a big deal, maybe even bringing the nurse into the picture, telling them they can come, have the nurse demo how to use the device, because some people are still uncomfortable with doing their own measurements the first time. So creating that as another option that they can bring the device in. This if it was like a glucometer, get teaching. Yeah, those are some of the tools that we've used. I think it's sort of the higher, SCS patients. I know Epic has a capability. I don't know if at Mount Sinai you guys are using it, but there's ways to link some of the devices to have the data directly go into their Epic sort of patient chart, my chart. So there's that raises some concerns, and I know different health centers are concerned, like, oh, if the blood pressure is really high, and now is the doctor responsible for this data 24 hours at a time? There's been certain solutions about it where the data only sort of comes across at the time of a visit, and otherwise it's sort of hidden. So there's other ways to sort of have the data come in without having to have the patient actually physically bring the device into the office.
Are you using a target that's 10 points lower than what it would be? Like, what's the target you're giving your patients for like a normal home blood pressure?
So that's a good. So there are guidelines on what the blood pressure goal should be. So if you use the older, more established guidelines than the new ACC HA ones, then if you use 140 over 90 as your office blood pressure, then the out-of-office goal is supposed to be 135 over 85. And that's based on a combination of sort of epi data as to how they sort of came up with the lower goal, sort of a trend towards a bit of a white coat effect in the office compared to out of the office, as to why it's a little bit different. With the new, more intensive goal, it's actually less than 130 over 80, which is sort of the numbers converge. It's like the in-office and out-of-office are the same as you get to a more intensive blood pressure goal.
I think that's actually take it up front. Thank you.
Okay, thanks for having me.